You've seen this patient 1,000 times, right? An older guy comes in, he's having trouble with urination. It is, without a doubt, one of the most common things we see in clinical practice. But the real question is, are you completely up to speed on the latest, most effective ways to manage it? Well, today, we are going to do a clinical deep dive into the 2023 AUA guidelines on BPH. Let's get you that clinical edge.
So here's the game plan. We're going to follow a patient's journey, right from the moment they walk into the clinic. We'll kick things off by really nailing down the what and the why of BPH. Then we get into the nitty-gritty of the diagnosis. And finally, we'll unpack the entire spectrum of treatments, from basic lifestyle tweaks all the way to the latest and greatest in surgical options. Okay, first things first. Before we can even start to help our patient, we all need to be speaking the exact same language. In the world of BPH, there are a few key terms that get thrown around, sometimes incorrectly. So let's clear those up right now so we can move forward with total precision. I want you to think of it like a traffic jam. BPH, the hyperplasia, that's the microscopic cause. It's like more and more cars getting onto the highway. Now that can lead to BPE, or enlargement, where the prostate itself actually gets bigger. But, and this is the key, it's only when you get BPO, benign prostatic obstruction, when the growth actually blocks the flow of traffic, that's the clinical problem that brings a patient knocking on your door. And that's exactly what we're here to fix. Just take a second and let that number sink in. 80%. By the time a man hits his 80s, there's an 8 in 10 chance he has the microscopic changes of BPH. That's not a typo. This isn't some rare disease we're talking about. For most men, it's a fundamental part of aging. So, if this is so incredibly common, what's actually pulling the strings biologically? Why does the prostate, after decades of being stable, suddenly decide to start growing again? Well, the answer lies with a very, very powerful hormone. Okay, think of testosterone as regular unleaded gasoline. It gets the job done in the body, but it's not super potent inside the prostate. But inside those prostate cells, you've got this enzyme called 5-alpha reductase. It acts like a turbocharger, converting that regular testosterone into a high-octane racing fuel called DHT. And it's this superfuel, DHT, that screams at the prostate cells to kick into overdrive and start multiplying. All right, let's slow down here. Picture this. Our patient is in the exam room. He's describing all his urinary issues. What's next? This is where the real clinical detective work begins. Let's walk through the AUA's recommended diagnostic pathway, step by methodical step. The AUA lays out a clear four-pronged attack. First and most importantly, we listen. We take a full, comprehensive medical history. Then we do the physical exam, which has to include a digital rectal exam to assess the prostate. Third, we use a validated questionnaire to actually put a number on his symptoms. And finally, a simple urinalysis helps us rule out other culprits, like a UTI or even bladder cancer. It's all about gathering these crucial clues to solve the case. So this is a huge question in medicine, right? How do you take a subjective complaint, like, I'm just really bothered by how I'm peeing, and turn it into something objective, something we can measure and track? Well, that is where the International Prostate Symptom Score, or IPSS, comes in. It's a remarkably powerful yet simple tool. The IPSS asks 7 specific questions about symptoms, like how often you have to strain or if you feel like your bladder is truly empty. You add up the scores and you get a total that tells you if the symptoms are mild, moderate, or severe. And this isn't just a number for the chart. It's a vital sign that guides our treatment choices and, crucially, lets us objectively measure if what we're doing is actually working. Now, this is an absolute game changer for how we counsel patients. Look at this data. It's not enough to just lower the IPSS score. For a patient to feel better, we need a significant drop. And the more severe their symptoms are at baseline, the bigger the improvement they need to feel satisfied. A guy starting at a 30 needs his score to drop by over 17 points just to be satisfied. This is critical for managing expectations before you even write a single prescription. Sometimes the initial workup doesn't give us the full picture. That's when we call in the heavy hitters. A post-void residual, or PVR, tells us how much urine is left behind after they go. Uroflowmetry? That's basically a speed gun for the urine stream. If that peak flow is under 10 milliliters per second, that strongly suggests a significant blockage. And of course, imaging gives us a literal roadmap of the prostate's size and anatomy, which is absolutely essential if we're thinking about any kind of procedure. Okay, we've got the diagnosis locked in. Now what? The AUA guideline is crystal clear on this point. The next step isn't just writing a prescription, it's having a conversation. This is where we sit down with our patient and figure out what matters most to them. Because the best treatment plan isn't found in a textbook, it's the one that's tailored to the individual sitting in front of you. I like to think of this as our treatment toolkit. We always start with the simplest tools first, behavioral changes, right? Fluid management, avoiding caffeine and alcohol. If those don't cut it, we reach for a more powerful tool, like medication. And if we need to, we've got a whole range of advanced surgical tools, from minimally invasive options to more definitive procedures. So let's open up that toolkit and see what's inside. All right, now we're getting into the true art and science of managing BPH, medical therapy. This is where the majority of our patients are treated. And it's where we have to be both a scientist and a strategist, picking the perfect drug for the perfect patient at the perfect time. Let's take a really close look at our options. We have two main classes of weapons in our medical arsenal. Think of alpha blockers like a plumber's snake. They work fast to relax the muscle and open up the pipes so things can start flowing again. 5-ARIs, on the other hand, they're more of a long-term fix. They go after the root cause, blocking that DHT turbocharger to actually shrink the prostate over months. The key is knowing when to use which tool. Alpha blockers for fast relief for almost anyone, 5-ARIs for men who we know have larger glands. And this right here is a clinical pearl that every single person prescribing these meds needs to know. Before you write that script for an alpha blocker, you have to ask your patient if they have cataract surgery planned. These drugs can cause something called intraoperative floppy iris syndrome. One simple question can prevent a serious complication and a huge headache for everyone involved. Now, for the patient with a large prostate and bothersome symptoms, this is the home run. We're not talking about a small effect here. The landmark MTOPS trial showed that combining these two drug classes leads to a 2/3 reduction in the risk of the BPH getting worse. That means preventing acute retention or needing surgery down the road. That is a massive win, and it's why the AUA gives combination therapy its highest strong recommendation. But what happens when medication just isn't cutting it? Or maybe the side effects are a problem, or the patient simply wants a more permanent solution. That's when we turn to our surgical toolkit. And as you're about to see, the options we have today are more advanced and more personalized than ever before. These are the red flags. If you see any of these serious complications, kidney damage from back pressure, bladder stones, recurrent infections, the inability to urinate at all, the time for just watching and waiting is over. At this point, surgery isn't just an option, it's a necessity, not just to improve their quality of life, but to prevent serious long-term harm. So how do we pick the right procedure? It all comes down to a conversation about two things, their anatomy and their priorities. If a patient has a really large gland and their number one goal is the best possible urinary flow, something like a laser nucleation, a hole-up, is a fantastic choice. But if they have a moderately sized prostate and preserving sexual function is at the top of their list, then you're going to be looking at minimally invasive options like POL or Rezum. It's all about tailoring the therapy to the man. And let's be really clear about this. For a huge number of men, a successful outcome isn't just about peeing better. It's about maintaining their sexual health. The new AUA guidelines absolutely reflect this reality, highlighting a whole class of treatments designed to do just that. Think of the prostatic urethral lift, or PUL, as putting in tiny little tiebacks for the prostate lobes. It just holds the tissue open, no cutting, no burning. Water vapor therapy, or WVDT, is more like a targeted strike. It uses steam to precisely remove the obstructive tissue while leaving the important surrounding structures untouched. They're both incredibly elegant solutions that really offer the best of both worlds, great symptom relief with an excellent chance of preserving sexual function. So, there you have it, a deep dive into the new landscape of BPH care. We have come so far from the old days of a one-size-fits-all surgery. Today, we have an entire arsenal of tools that let us tailor treatment to the individual. And that really leaves us with a fundamental question to think about. In this new era of personalized medicine, what is our definition of success? Is it a number on a flow rate test? Or is it the look on a patient's face when he tells you he finally has his life back? Thanks so much for joining me.